Good morning. Today we are going to start an actual body system, musculoskeletal system. So chapter 45 in your textbook, and I've modified the PowerPoint so that you can follow along with me. All right, so what are we going to achieve when we go through this? Well, you're going to make sure that you understand how to explain the anatomy and the function of the musculoskeletal system. You're going to describe the effects that aging has on the musculoskeletal system. That's for other people, but not me. Subjective and objective data and how you will document when you're assessing the musculoskeletal system. Specific kinds of questions that you want to ask patients. You're going to understand how the neurological system, which is the next system that we're going to cover, works in sync with the musculoskeletal system. One can't work without the other. We're going to talk about the diagnostic tests that are used to help diagnose different problems with the musculoskeletal system. And then most importantly, what is your job as the nurse when you're caring for somebody? You'll see when you start having questions about these things, it's always going to be relevant to what do you as the nurse do to help this patient. So musculoskeletal system, what do we have? We have bones. We have cartilage, and then we have ligaments. We also have fascia. We have tendons. The way to remember it is tendons are kind of like rubber bands that connect bone and muscle, okay? So what is the skeletal system for? Well, without it, you wouldn't be able to stand or move. A lot of it has to do with protection. Think about it. We have a rib cage. Why? The rib cage is protection for the organs that are in the thoracic cavity, your heart, your lungs, right? And then last but not least, the bones store calcium. And there's also one more thing that's not listed, but that I have added in here. When we talk about functions, you have to remember, in the bone marrow, it's important to remember this because this is going to come up over and over and over again. The bone marrow is where all blood cells are made. So red blood cells, white blood cells, and platelets. And typically that's in the long bones. If you remember way back when you had body structure and function, in kids there's yellow bone marrow and there's red bone marrow. And then that changes as adults, right? So as adults, the red bone marrow is where the blood cells are actually made. And that's in your long bones like your femur, right? Which is the longest bone in the body. So that's important to remember. Don't forget it. We're going to talk about skeletal muscle and connective tissue like the tendons. Make sure that you understand how that works. So when you hear about, say, you're into sports and people have injuries, distal bicep tendon can be ruptured. If the tendon ruptures, it can no longer connect the muscle to the bone, right? More functions of the musculoskeletal system. Movement. You can run, you can walk, you can stand up, you can sit down. Helps to produce heat in the body. And here's another thing, and this is super, super important. I'm actually going to put a few stars after it. We have a heart, and our heart pumps blood through the arteries. So while it's pumping, that is the force that sends the oxygenated blood to all of your extremities, right? All the way down to the tips of your fingers and the tips of your toes. Well, veins, they return blood back to the heart. They don't have a pumping system, right? So how does the blood get back to the heart? Movement. That is why, as nurses, we are constantly yelling about prevent immobility and early ambulation, why those things are so important. Because in order for blood return to occur, you have to move. Ambulation, when you walk, the muscles are moving and squeezing the blood up the veins and back to the heart, okay? And as they do it, the valves in the veins are there for a reason. They will open, the blood goes up, they slam shut. Open, blood goes up, they slam shut. So don't forget it. That's very important to remember. When we talk about bone tissue, I'm not going to, get into this deeply, but osteocytes are the cells that basically make bone tissue. That's how bones can repair themselves, like if you break a bone. We're going to talk more about pathophys when we get to chapter 46. there is a lovely diagram of the skeleton. We all have 206 bones. Now, do you have to know the name of every single bone? You do not. However, there are some bones that you really do need to know the names of. You need to know their location. You need to be able to document accordingly. So if someone says, oh, Mrs. Jones had a tib-fib fracture, your brain goes, oh, tibia and fibula, the two bones of the lower leg, right? Or the femur, the longest bone in the body that's in the thigh. Okay, so make sure that you understand the location of bones like the femur, the tib, the fib. Make sure you understand the upper arms. You have the radius, and you have the ulnar, and then up here you have the humerus. Have you ever banged your elbow and it sends like pins and needles up your arm, and you'll say, "Oh, I hit my funny bone." It's a funny bone. Guess why? Because it's called the humerus. Get it? Funny bone? Anyway, I know it's early for this kind of humor. Your skeleton's divided up kind of into two parts. You have the axial skeleton. The axial skeleton is kind of like your core, right? It's your skull, your hyoid, your vertebral column, and your rib cage. And then the appendicular skeleton is everything else, your extremities, right? The things that move, okay? Including all the joints that move as well. Your skull, you have the anterior and lateral skull, great picture here. And you want to at least understand, again, not every single bone, but do you know that the jawbone is the mandible and the facial, the cheekbones, maxilla, frontal, occipital? They're things that you definitely need to know so that when you're charting, you can chart appropriately. When we talk about your spine, you have your vertebral column. So from your brain, you have a spinal cord. It goes down your back, right down the center of your back. And the spinal cord is inside the spinal or vertebral column. And it's protected by vertebrae. Here's the way to remember how many there are. If you look at this slide, cervical, right? Cervical vertebrae, you have 7. Thoracic, you have 12. Lumbar, you have 5. And yes, sacrum, but the 5 of those at the sacrum and the coccyx, 4, they're fused together, kind of like a tail. But remember, you eat breakfast at 7, you eat lunch at 12, and dinner at 5. So cervical, thoracic, lumbar. See? That's the way to remember it. And when you look at the curvature of the spine, and this is a side view of the human, do you see the natural, normal curvature of the spine? That's the way it should look. Well, sometimes things can go wrong. There can be deformities. Here are the 3 that you need to know. Kyphosis. So I call that the hunchback of Notre Dame. That's hunched over, right? We also have lordosis. I call that the duck. Because there's kind of like a bowing at the bottom or the base of the spine that kind of makes the butt stick out. For those of you that have kids, when you were pregnant, towards the end of the pregnancy, super big, didn't you kind of walk funny to compensate, right? You kind of lean back like this and butt sticking out to compensate for the belly. Well, that's lordosis. And then last but not least, we have scoliosis. Scoliosis is a lateral curvature of the spine. Normally in school nurses will typically, and at regular intervals, check students for scoliosis because most often it's apparent when kids are 10, 12, 13 years old. How can you tell? Well, when you look at someone from behind and you have one shoulder that's lower than the other, that's usually a telltale sign of scoliosis. And then you can have them bend over forward, and when you look at their spine, you should be able to see a nice straight line, okay? If you don't, scoliosis. Okay, moving on. So the next slide, the thoracic cage. And that's what we call it. It's kind of like a cage because it includes the ribs, again, which are protection. And that's important to remember. So the ribs protect everything that's inside the thoracic cavity. Your heart, your lungs, your liver, your spleen. And the ribs, they're not really stationary. They have give. So when you inhale, take a deep breath in, your rib cage expands. When you exhale, your rib cage will contract. So it allows for inspiration and expiration. When we talk about joints, and I'm not talking about the good kind, joints are where bones actually connect and allow for movement and different kinds of movement. So the most common ones, and these are the two that I really want to talk about, are the knee, and that's one where you will see injury that happens with age. So you have the knee joint. Inside that synovial joint, there is a cavity that is filled with fluid, synovial fluid. Think about synovial fluid the way you think about oil in your car engine, if you think about oil in your car engine. So it's kind of like a lubricant. It's in there for a reason. It prevents bone on bone. So, when we're young and we're healthy, usually plenty of synovial fluid, plenty of lubrication. As we age, osteoarthritis, and don't confuse that with rheumatoid arthritis. When we say osteoarthritis, osteo meaning bone, arthritis is inflammation of. And so over time, with age, again, that's other people, it's not me, things wear out. And those joints can actually start to wear out. Other risk factors include obesity. Joints are not meant to hold 350 or 400 pounds of people. When you put undue pressure on them, if you are a runner or a jogger, high impact will put undue wear and tear on the joints. And over time, what can happen is, well, lots of things. Arthritis is actually like the rubbing of bone on bone and inflammation in the joint. Very painful. Stiffness, very common with older people. Cold makes it worse, and heat makes it better. Osteoarthritis, remember that, okay? And I think that's about it for that. When we look at the skeletal muscles, you have bones, but you have muscles connected to the bones. And these are the things that actually allow for movement, right? And remember, they're anchored to the bones by tendons. They're kind of like rubber bands, right? They give. So if I want to make a muscle, I can make a muscle. If I want to relax it, I can. And that all happens because this muscle is attached to the bones. Do you need to know the name of every single muscle in the body? You absolutely do not. But there are some muscles you do need to know the names of. So I'm going to back the camera up and talk about the ones that you need to know, because when we talk about injections, intramuscular injections, there are very specific sites that need to be utilized. If you are giving an IM, intramuscular injection, to an infant or a baby, there is one location. That is the muscle called the vastus lateralis, which is in the anterior thigh, okay? If you are giving an IM injection to an adult, there are two locations, count them, two. The first one is the deltoid. When you look at somebody's arm, I'm going to try to get this in the picture and show you my guns. The deltoid is right here. You can feel the muscle, okay? That is the deltoid. And then the other one is ventrogluteal. How do you find that bad boy? I'm glad you asked. Let me show you. So when you are looking for the ventrogluteal, when you look at your patient, you're going to find the iliac crest. That's your hip bone, okay? You're going to take your hand and you're going to place it. I have to do it upside down because I'm doing it to myself. The thumb on the iliac crest. Spread your fingers, and right between the first and second finger, right about here, the hip, that is the ventrogluteal muscle, okay? Those are the only two acceptable sites for IM injections in adults, deltoid and the ventrogluteal. And then vastus lateralis, babies. Okay, so make sure that you know that forever and ever and ever and ever. When we talk about muscle structure, you got about 700 muscles, and muscle strength is super important. I mean, I cannot emphasize enough how important it is for lots of reasons. If you maintain good muscle tone, you will avoid things like osteoporosis. Okay? Osteoporosis, osteo meaning bone, porosis sounds like porous, right? Well, that's what it is. It's bones that become porous, kind of like a sponge in the older years. The common victims of this are postmenopausal women, others not me. And that has to do with a lack of estrogen. We'll get more into that when we get to chapter 46. But one of the ways to ward off osteoporosis, weight-bearing exercises, not cardio, weight-bearing. In other words, building strength helps to ward off osteoporosis. Okay, so don't forget that. When we talk about the neurological system and how it relates to the musculoskeletal system, remember, your brain, central nervous system, has to send a message to the nerves, and the nerves have to innervate the muscle to move the bone, right? Pretty complex, but you don't really think about it. If I want to stand up, it's this quick, boom, and I'm up, right? Sit back down. That's how quickly the brain sends the message. Boom, stand up. Okay, I'm up and I'm down. The nerves and the muscles communicate with each other with something called acetylcholine. And acetylcholine is a neurotransmitter. So neurotransmitter means it is transmitting signals from the nerves to the muscles, okay? Acetylcholine is important to remember. I don't get into detail about all the neurotransmitters, but this one is important because there's an autoimmune disorder called myasthenia gravis, which I call ragdoll syndrome, and you'll understand why when we get to chapter 46. That acetylcholine, without it, your nerves can't communicate with your muscles. And if that can't happen, guess what you are? A ragdoll, right? Make sense? Okay. The next slide gets into aging and the musculoskeletal system, and there are things that you do need to know. Wear and tear, muscle strength loss, calcium loss in the bone. All these things can relate to joint pain, joint stiffness, falls, and then subsequent fractures. So how many times have you heard, oh, did you hear Mrs. Jones took a fall, she broke her hip, and the next thing you knew, she was dead. Well, was it the fracture that killed her? No. Usually it is the subsequent sequelae of the complications of the surgical repair of the fracture. That's the problem. And we are going to talk in chapter 46 in depth about knee arthroscopy and arthroplasty, hip arthroplasty. They're the things that you're going to see the most of, and the board will ask you about them, and so will ATI. Okay? So, it's important to make sure, like I said, for your older patients, if they have not taken, care of themselves back then, they have to be careful. Fall precautions, right? Very important. Want to make sure that they are as independent as possible for as long as possible. Okay, when you are assessing a patient, you're going to be getting subjective and objective data. So the subjective data is the information that you're going to accumulate from your patient. History, injuries. Have you had any injuries, any fractures? What do you do for a living? Or if you're retired, what did you do for a living, right? That's important because people's occupation has an impact on what happens later in life. Were you sedentary? Did you sit behind a desk most of your life? It's not good. Or were you out moving around? Were you a lumberjack, cutting down trees and stuff? So, occupation, family history. I cannot emphasize enough. Genetics are the card that you are dealt. They're the cards that you're dealt. And you can't modify your genetics. They are what they are. So if your family history has, say, bone cancer, well, you're automatically a higher risk. Does it guarantee that you're going to get it? No, of course not. Of course not. But it definitely makes you a higher risk for whatever diseases run in the family, okay? Nutrition. And here is another one that I can't emphasize enough. Remember the old saying, well, most of you may be too young, but you are what you eat. It's true. You are what you eat. If you live on fast food, McDonald's, you drink a Pepsi from a cup that's as big as a trough. Right now, not a big deal because you're young. But when you get older, it's going to have consequences. You really have to take care of yourself now so that later you don't have all these problems. Okay, I can't say this enough. We're going to talk also to the patient about psychosocial issues, right? So in other words, let's say you have a patient with severe kyphosis. Maybe she's got some, body image disturbances. There's a nursing diagnosis associated with that due to that deformity. Well, that's important to find out about. How does she feel about herself, okay? Next, we're talking about physical inspection. When you meet a patient for the first time, and I promise you, you're going to see how real this is. Before you even say hello and introduce yourself, you're looking at the patient, okay? You're looking at the patient as far as nutritionally. What does their skin look like? How is their stature, their posture? Are they standing up straight? Are they well-nourished, which, means that they're good within normal limits? Or are they obese? Or do they look malnourished? Then when you start to talk to them and assess them, you're going to start inspecting. You're looking for things like range of motion. Here's a good example. Rotator cuff injuries. Rotator cuff is a combination of things that are in your shoulder that let your shoulder do things like extend your arm and then raise it over your head like that. When you're assessing a patient, if you're looking for range of motion and you ask them to do this and they can only get like right there, guess what? They may have a rotator cuff injury. So range of motion, their muscle tone, right? Do they have some strength behind them or are their muscles very flaccid? These are all important things that you're going to be looking at. You're going to be assessing people when you're walking through ShopRite after I'm done with you. I promise you, I do it all the time. I think I covered everything as far as inspection, range of motion, muscle tone. Oh, palpation. The other thing that you're going to be looking at, especially at the joints, and especially for the older population, the wrist, the elbow, the shoulder, the hip, the knee, the ankle, okay? Is there swelling? Is there, redness or warmth at the joints? That's important to note. Is there tenderness? So tenderness to touch. In other words, when you touch it, it hurts. These are all important things. And we'll talk again, chapter 46 gets into great detail about the pathophys. Okay, tests, diagnostic tests. We are not going to get into all of them, but I'll tell you the ones that you need to know. So you need to know serum calcium levels. Okay, that's important. And here's where we're going to get started again with understanding lab values. So make sure that you know serum calcium, 8 to 10. Serum calcium, 8 to 10. Okay, that's important for you to know. We will talk about alkaline phosphatase also, and we will talk about uric acid. And that's where it's going to end. So they're the three that we're going to focus in on with regard to the musculoskeletal system. And I've got those highlighted, so this way you know. For diagnostic tests, there are invasive and non-invasive tests that we can do. When you think about non-invasive tests, the most common one for musculoskeletal, it's an X-ray, right? We are going to take radiographic waves and take a picture and look at the bone. An X-ray can clearly show us things like fractures, breaks in bones. Can't really show us, soft tissue and those kinds of things. That's a CT scan or MRI would do better with that. But X-rays can show us if the bone is broken or dislocated. And then we have bone density scan. And again, I've highlighted these in the PowerPoint. If we're concerned about osteoporosis, we can do a test called a bone density scan. And basically, it's kind of like a CT scan, but we're looking at the patient's bones and we will look to see how dense they are. If they are not dense, nice and solid, right, to provide strength, start to get porous, then we diagnose the patient with osteoporosis. Okay. And then invasively, there are things we can do like an arthrocentesis or arthroscopy. So whenever you see centesis at the end of a word, that means fluid removal, okay? And arthro is referring to the joint, okay? Arthrocentesis. They've got swelling in the knee. You ever heard somebody say, I got water on my knee? Well, it's not water, right? It's excess synovial fluid that's kind of stuck in the bursae, the capsule inside the knee. We take a needle and we go in to the joint and we aspirate or draw out the fluid. Arthrocentesis. Arthroscopy. Whenever you see OSCOPY, oscopy at the end, well, what does that mean? We're taking a scope, right? Kind of like, not a telescope, right? But it's an itty bitty little scope, like a catheter, to go into the joint so that we can look in great detail what's going on inside the joint. And it helps us diagnose different things. Very common with knees, most common with knees. All right. Well, I hope that you had fun with this one. The next one's going to be even more interesting because pathophys. So now you know how it's supposed to work when it's working right. Now we're going to talk about what happens when it's broken. Until then, peace, kids. See you later. Okay, bye.